Imaging of articular cartilage. I am Dr. Arun. Firstly, I would like to welcome our chief guest, Dr. Sunil Apsingi, sir. Good afternoon on the board, sir. I welcome you on behalf of Vijaya Diagnostics for this webinar, sir. Some brief introduction about our chief guest of today, that is Dr. Sunil. He has done his MBBS from University of Health Sciences AP, following which he did MS in Orthopaedics from PGI Chandigarh, and then MRCS from RCR Colleges, Edinburgh. Presently, he is working as the Director of Orthopaedics in Sunshine Hospital, HITEC City, Madhapur. His employment record is too vast, starting from Kakatiya Medical College, and then he has done a lot of posts in UK and in India, and following which he was employed with the KIMS Hospital, Hyderabad before this. He has got a lot of research papers and international and national publications, a very big list. I think that will take another 1 hour to describe all those lists. So I would like to cut short this, and a lot of book chapters are also written. We are very happy to see so much presentations, sir. A lot of courses and conferences he has attended, and even a lot of presentations, sir.
Right now, I'm with Medicover HITEC City.
Yeah, okay, sir. Right now, he is working as an orthopedic chief consultant in Medicover HITEC City, sir. So that is a brief introduction about our sir. Welcome on the board, sir. I would like Dr. Vikram also, I would like to introduce him before he starts his presentation. Dr. Vikram Reddy has done his undergraduation from WIMS Bellary, and he has done his post-graduation from GS Medical College in KM Hospital, Mumbai. Following which he worked in some centers in Karnataka, following which he has joined in Vijaya for the last 1.5 to 2 years. He is working with us. And he has also got a lot, very good distinctive past record with a lot of publications and achievements. Over to you, Mr. Vikram, for continuation of the presentation. Thank you.
Thank you, Arun sir, for the introduction. Thank you, Sunil sir, for being part of this webinar. Today I'll be speaking on articular imaging of articular cartilage. Is my screen visible, sir?
Yes.
Today's topic of VDC webinar series is imaging of articular cartilage. So the articular cartilage of joints in the human body is lined by hyaline cartilage. The primary role of the cartilage is to distribute force and to reduce friction and prevent wear and tear of the joints. The lack of lymphatics, neural and vascular structures in the joint precludes the possibility of regeneration if there is any cartilage damage. It is important to know the composition of hyaline cartilage. It is predominantly made up of water by 75 to 85%. Followed by type 2 collagen, proteoglycans, and chondrocytes. The layers of articular cartilage is important to know because the appearance of the articular cartilage may differ on MRI based on the location of the cartilage. It is mainly made up of 5 layers. That is a superficial zone where that is outermost layer with the fibers are in parallel orientation. It basically acts as a cushion distributing the impact of the compressive forces. Then it is followed by the middle zone made up of transitional fibers and the deep zone where the fibers are in radial orientation. Then it is followed by a tide mark zone, which is the junction between the cartilage and the bone. Then underlying it is a subchondral bone. So these are the layers which can be delineated. Some of the layers can be delineated on MRI, where we have a hyperintense superficial layer, intermediate to hyperintense middle and deeper zone, and a hypointense tide mark and a subchondral bone plate. We must also know there are regional variations in the MRI signal based on the location of the cartilage. In central weight-bearing portions of any joint, the radial fibers make the bulk of the cartilage tissue, which are radially oriented. So it gives a predominant intermediate to dark signal. Whereas the peripheral cartilage is mainly made up of transitional fibers, so it gives a relatively hyperintense signal as compared to the central portion. So this must be kept in mind before any interpretation of any cartilage injuries. So coming to MR techniques, if available, 3 Tesla is better for cartilage assessment because there is an increased signal to noise ratio and a greater spatial resolution. We can assess the cartilage based by 2 methods, that is morphological assessment and compositional assessment. In morphological assessment, we see for the morphology of the cartilage, is there any damage. In composition, we see what is the changes in the composition of the cartilage before any morphological changes appear. So coming to morphological assessment, here are the basic 2D spin echo sequences. T1 sequence is not much helpful for cartilage assessment because there is lack of good contrast, tissue contrast between the cartilage and the dark joint fluid. However, T1 might be used in MR arthrograms. T2 is a good sequence where we have excellent contrast difference between the fluid and cartilage interface, but the intrinsic signal of the cartilage is hypointense, so we can't really assess what is going on within the cartilage. So we can only see what is going at the surface of the cartilage. Among these three, PD is a better sequence where we have an intermediate to low signal of the cartilage, and we can also see the very good interface between the superficial layer and the adjacent joint fluid. So PD is more helpful for focal surface lesions. Nowadays, most of the protocols of MSK include intermediate weighted sequences. So this usually combines the advantage between the PD sequence and the T2 sequence by adjusting the TE to between 33 to 60 milliseconds. The advantages of these intermediate weighted sequences is there is increased overall signal intensity of the cartilage as compared to a T2 weighted sequence. It also allows in better differentiation between the cartilage and the subchondral bone. And also these sequences are less susceptible to magic angle artifacts which are seen in PD sequences. So here is an intermediate weighted sequence where we have a nicely bright articular cartilage and a good contrast between the surface and the joint fluid. In the assessment of articular cartilage, it is better to use volumetric or 3D sequences because we can do a multiplanar reformatting, and it is easier to pick up any small lesions which are usually missed on 2D sequences. But the limitations are a long acquisition time and increased susceptibility to motion artifacts. Usually fat suppression is added to volumetric sequences to reduce the chemical shift artifacts which we usually see at the subchondral cartilage junction. According to ICRS, that is the International Cartilage Repair Society, 3D SPGR sequences is the recommended standard sequence for imaging of articular cartilage lesions, especially in post-op cases. There are multiple 3D sequences across with multiple names across various vendors. These can be broadly classified into two categories. That is dark fluid sequences, which are basically T1 GRE sequences. They include SPGR sequence or flash sequence. Here we have a nice bright articular cartilage with hypointense joint fluid. The other is bright fluid sequences or T2 weighted GRE sequences. The multiple sequence names are DES sequence, DEF sequence, or GRASS sequence. In these bright fluid sequences, we have high contrast between the synovial fluid and the dark cartilage. MR arthrography is usually reserved for any post-op cases for a cartilage assessment. It can also be used when the cartilage thickness is very thin, such as in shoulder joint. In knee joint, it is not of much use. So what we do is we instill contrast into the joint space, which outlines the contour. So the cartilage defects and the labral tears can be easily delineated. Next, coming to compositional imaging of cartilage, it aims to detect biochemical and microstructural changes in the cartilage matrix even before the morphological changes occur. As we know, cartilage is mainly made up of water, glycosamine glycans, and collagen. Any changes in these components will result in a compositional change of the cartilage even before any morphological changes occur. So we need to so these sequences help in quantifying those lesions. Based on the type of the component, there are multiple sequences. Like T2 mapping is a sequence where we measure the water content and the collagen structure. There is another sequence called as T1 row mapping, where it measures the glycosamine glycogen content. And another is a digimeric sequence. It is a contrast-based technique. It is also for the glycosamine glycan estimation. Coming to most commonly used and clinically validated compositional imaging technique, that is T2 cartilage mapping, or also known as cartogram. So in morphological assessment, due to limitations in the imaging sequences, there is low sensitivity to detect any early cartilage degeneration. So what we do in T2 cartogram is T2 values are calculated by obtaining multiple signal intensities at various echo times from a multi-echo sequences. Further, these values are computed in a in the form of a color-coded or a grayscale map representing the variations in relaxation times. So in abnormal cartilage, there is decreased proteoglycan content, increased water content, and more disorganization of the collagen fibers, which in turn results in increase in T2 relaxation values. Whereas in a healthy cartilage, the water molecules are tightly bound to the well-organized collagen, which exhibits low T2 values. So that is the principle behind T2 cartilage mapping. In normal patients, it is of not much use unless it can be used in amateur or professional athletes where there is suspicion of early cartilage degeneration. Also in patients with loading axis alteration. T2 cardiogram is mainly useful in patients to detect intrasubstantial cartilage alterations in post-surgical and patients who are on follow-up for conservative follow-up for chondral injuries. Also, this method can be used to study the progress of the chondral alterations when the patient is put upon any pharmacological therapy for a chondral injury. So, in accordance with the literature, the threshold for normal T2 values is set at 40 milliseconds. So, T2 mapping is considered as positive if any chondral lesion shows a T2 relaxation of more than 40 milliseconds on at least 2 slices. During T2 cartilage mapping, it is important to mention the exact location of the chondral lesion so that the surgeon can go in and intervene. So just for the sake of standardization, the knee joint is divided into anterior, central, and posterior. For the femoral condyle, a line is drawn from the outer margin of the menisci, which divides into anterior, central, and posterior. For the tibial cartilage, the central portion is small. It is between the free margins of the anterior and posterior horns of the menisci. In the patella, we can divide it as medial and lateral facets, which can further be divided into superior, middle, and central quadrants. These are some of the examples for T2 cartilage mapping. Here we have a subtle hyperintense signal in the patellar facet, which shows increased T2 relaxation values. This is represented by a green to bluish signal as compared to the normal adjacent cartilage. So this is one lesion which can be easily missed on morphometric analysis, where we have a subtle diffuse hyperintense signal which can be passed off as normal. However, on T2 cardiogram values, T2 cardiogram study, we can easily see that there is diffuse increase in relaxation values of the cartilage, indicating early cartilage degeneration. This is another case where there is a small superficial subchondral fissure which shows increased relaxation values. The other clinically validated compositional technique is the degemetic sequence, that is delayed gadolinium enhancement, MR imaging of cartilage. So what degemetic technique involves is the ions within the interstitial fluid in the hyaline cartilage are distributed in relation to the concentration of negatively charged glycosamine glycans. So what in degemetic sequence, what we do is we inject IV contrast, that is gadolinium, and we do the study after 90 minutes after injection, so that the contrast from the blood goes into the joint and further into the articular cartilage. Gadolinium is a positive charge ion, whereas GAG is a negative charge ion. So what degemetic sequence is it measures the concentration of gadolinium per voxel in that portion of the cartilage. A higher degemetic index means the higher GAG contents, that is the cartilage is normal. So this is the example of a degemetic sequence. On the left side is a normal degemetic sequence where we have a homogeneous signal, homogeneous greenish signal along the cartilage. This is the abnormal degemetic. This is the abnormal degemetic scan where we have decrease in the degemetic values. That is, it is reddish in color, which corresponds to around 150 to 300. So we have a degemetic index. Usually, this is not much used across cartilage imaging as compared to T2 cardiogram. So there are various other compositional techniques. However, they are not clinically validated. Among the techniques, only these two are tested in clinical trials, that is T2 mapping and the degemetic sequence. Degemetic is less employed because it needs IV contrast injection. So coming to cartilage damage morphology, there are multiple terminologies where we can describe the cartilage. It is better to use the standard lexicon so that we can convey the findings better to the surgeon. So chondral fracture means it is usually reserved for cases where we have a acute trauma. Damage is an umbrella term where it can be used for any articular cartilage abnormalities. Defect is when there is loss of height of the cartilage. Degeneration is used when there is a chronic appearance of the cartilage with shallow margins, subchondral cysts, and subchondral sclerosis. Chondromalacia is the general use of term chondromalacia is discouraged as it confuses with the specific category of cartilage softening. We'll be seeing rest of the findings in detail. So from initial staging, this is a case with a hyperintense lesion, that is swelling in the articular cartilage. There is focal increase in signal intensity in the cartilage with no significant thinning. This is another case where we have a reverse, that is the hypointense signal within the cartilage. This is also called as a dark cartilage sign or a black line sign. Both indicate the same thing, that is there is some ongoing partial thickness degeneration. So these are the early findings which we can see on a morphological imaging of cartilage degeneration. Coming to next, this is a superficial partial thickness cartilage fissuring in the patella. We can see the alterations along the superficial layer, and also there is some intrasubstance degeneration in the deeper layers, which is also confirmed on arthrography, indicating regional chondral degeneration. This is a deep partial thickness cartilage flap, where we have a deep fissure along with a focal delamination going along the surface of the cartilage. So we have some residual tissue remaining along the deeper zone. So this is another case where we have a flap which is attached to one side. So these are examples of deep partial thickness cartilage injuries or flaps. Then there is full thickness cartilage defect. Here we can see there is a full thickness chondral defect along the humeral cartilage, which corresponds to the arthrographic image, where we have a full thickness chondral defect where the bone is exposed to the joint space. Also, we can see some superficial cartilage damages in adjacent glenoid fossa. This is a case of chondral flap where a piece of cartilage is hinged to one side of the cartilage. If you remove the flap, it would yield a defect. This is the definition of the chondral flap. Usually these are acute injuries. Then there is chondral delamination. As we discussed in the layers of the cartilage, there is something called as a tide mark zone. So when there is a shearing force type of injury, there is delamination along the tide mark zone, that is between the cartilage and the bone. We see a fluid signal extending along the tide mark zone. Sometimes this may be filled with fluid, beautifully demonstrating the chondral delamination. It is important to distinguish between acute traumatic and degenerative cartilage lesions. Acute traumatic cartilage lesions are usually sharply demarcated chondral lesions with narrow zone of transition. These examples include any osteochondral fractures, chondral fissures, flaps, as we discussed on any osteochondral impaction injuries. Cartilage degenerations are usually shallow chondral defects with wide zone of transition, where we see diffuse chondral thinning, varying degrees of bone marrow edema like signal or subchondral cysts or sclerotic changes. Modified outbridge grading is what we usually tend to use in a clinical practice. This grading was usually devised for arthroscopy for assessment of chondromalacia patella. Then it was modified and extended to all chondral surface in the body. So there are basically 4 grades. Grade 1 is intrinsic signal abnormality with no reduction in thickness. Grade 2 is less than 50% cartilage loss. Grade 3 is more than 50% cartilage loss, and grade 4 is full thickness cartilage loss. So these grading are also correlated with the arthroscopic findings of softening in grade 1, superficial fissuring in grade 2, any deep fissuring ulcerations in grade 3, and exposed or denuded bone in grade 4. Some of the examples of modified outbridge classification, this is a grade 1. There's some subtle signal abnormalities in the tibial cartilage, whereas an arthroscopy correlated to the softening of the cartilage. It is very difficult to perceive and easily missed on routine imaging. This is a grade 2 cartilage damage where there is less than 50% attenuation of the cartilage, and on arthroscopy we have a superficial partial thickness damage. This is a grade 3 lesion. We have diffuse hyperintense signal with chondral fissure and also small delamination flap extending along the deeper layer. On arthroscopy, it correlated with the deep cartilage fissuring in the trochlea. We can also see some similar changes in the patellar articular cartilage. This is a grade 4. So this is acute cartilage damage. As we discussed before, it has very sharp margins, has also a narrow zone of transition. So this is a grade 4 acute chondral damage in the trochlear cartilage. Although this look, the appearance is not is very subtle on the sagittal images. On arthroscopy, there was a large cartilage flap, which was demonstrated. Following debridement, we had a full thickness defect in the cartilage with the exposed bone underneath it. The other grading is a ICRS grading, that is International Cartilage Repair Society grading of focal chondral lesions. It is more or less similar to the modified Outbridge classification with few small changes. Like grade 1 has been further subdivided into 1A and 1B. 1A remains the same, that is intrinsic signal abnormalities with no loss of cartilage thickness. Grade 1B is some superficial fissuring or lacerations. Then we have some changes in grade 3, where in modified Outbridge, the chondral blisters, delaminations, and chondral flaps were not included. So these are included in the newer ICRS grading. Then grade 4 is the same, that is full thickness chondral loss with subchondral edema like changes. So these are examples from grade 1 to grade 4 according to ICRS staging. These are more or less similar to the modified Outbridge staging. Next, coming to, we have discussed what is the lexicon or terminologies to describe any cartilage lesions. We are discussed the staging by modified Outbridge and ICRS grading. Next, coming to articular cartilage repair procedures, the cartilage itself doesn't have as limited capability to repair. So there are multiple surgical procedures that have developed to treat these cartilage defects. So they can be categorized as bone marrow stimulation procedures, which include abrasion, arthroplasties, microfractures, or subchondral trimmings. The other is tissue-based cartilage repair, that is autologous osteochondral autograft transplantation, also called mosaic plasty or Oates procedure. The another is osteochondral allograft. This is autograft. This is an allograft transplantation where the cartilage is osteochondral implant is taken from a cadaver. Then there is cell-based cartilage repair, where that is autologous chondrocyte implantation or ACI technique. So coming to bone marrow stimulation procedures, which these procedures, that is the microfractures, subchondral drilling, they rely on a principle that formation of a fibrin clot within the defect by creating bleeding from penetration of the subchondral bone. The penetration may be due to microfractures or subchondral drilling. So what this fibrin clot does is it has pluripotent stem cells that further differentiates and remodels, leading to formation of a fibrocartilage. Since we are replacing the hyaline cartilage with the fibrocartilage, so we should not expect the signal abnormality to be similar to the native normal fibrocartilage. So initially the cartilage might show hyperintense signal. So this must not be confused for some ongoing cartilage damage, but this is a normal phenomenon. Over time, the signal intensity will decrease as the cartilage will mature, and also the subchondral edema will decrease. In some patients, we might see bony overgrowth, but this doesn't have any negative effect on clinical outcome scores. Persistent bone marrow edema, incomplete filling of the defect are some of the signs which indicate treatment failure. So these are some of the examples of microfracture where this is a post-op case of microfracture where there is good amount of cartilage overgrowth over the microfracture side. There is some amount of residual partial thickness filling in the anterior margins. So this is one of the example where the bone has overgrown into the cartilage, but the outer margin of the cartilage is well integrated with the native cartilage. So this means the procedure is successful. So in these patients with bone marrow stimulation procedures, as radiologists, what we need to look is what is the degree of the filling. In post-op cases, it is important to mention the degree in terms of percentage for better follow-ups. And also we need to mention the morphological characteristics of the reparative tissue, whether it is hypointense, hyperintense, or it has integrated with the native cartilage. And also we need to mention if there is any presence or absence of any delamination, and what is the extent of the peripheral integration, like any fissures or flaps are present at the margins of the procedure. Next is the tissue-based cartilage repair, that is Oates procedure. So in this procedure, osteochondral plaques are harvested from a non-weight-bearing areas like a trochlear or lateral femoral cartilage, and they are transplanted into the articular defect or cartilage defect in the same person. So since it is autologous procedure, there is less chance of graft rejection. Usually these procedures are reserved for cartilage defects sizing between 1 to 4 centimeters square. These also can be used in patients with osteochondritis dissecans and osteonecrosis. So this is an example of Oates procedure where the osteochondral plugs are removed from the non-weight-bearing trochlear cartilage and they are harvested into the weight-bearing medial femoral cartilage. So in this case, we can see there is good osseous integration with some linear lines indicating two plugs were inserted into it. There is good amount of cartilage integration with the adjacent native cartilage. So this is another example for good Oates procedure where there is good integration of the osteochondral plugs in the medial femoral condyle. There are some high intensity changes in the fissure at the medial margin mainly. So sometimes there might be bony overgrowth in these cases. So this is an example where the osseous portions are protruding into the cartilage. However, the cartilage as such shows a good integration with adjacent native cartilage. Oates procedure is one place where we can make use of the T2 cartogram or T2 cartilage mapping to assess what is the status of the cartilage, to see the relaxation values, whether it has a cartilage with good integration will show values of less than 40 milliseconds. So in these patients, what we need to look is what is the degree of filling of the cartilage, what is the restoration of. Also, we need to look for any radial curvature, congruity or restoration of the radial curvature. We need to mention what is the integration of the both osseous and the cartilageous component. Also, we need to mention are there any subchondral bone changes. The last is the cell-based cartilage repair. This is a two-step procedure where in the first step, cartilage is harvested from a normal site. Then it is cultured for 3 to 5 weeks. Then in the second procedure through arthrotomy, this cartilage harvest is put into the cartilage defect and covered by a periosteal flap. Nowadays, they also use the matrix Macy procedure, that is matrix-assisted chondrocyte implantation. So what we as in post-op imagings of cartilage, what we need to look is for four things. What is the filling of the articular cartilage? What is the congruity of the cartilage? That is the bone of the curvature of the bone must be in a smooth fashion. If there is some offset or onset of the osteochondral plugs in later stages, it might lead to some biomechanical disturbance in the joint, leading to failure of the osteochondral graft. Also, we need to mention if there is an edema in the subchondral bone, which is a bad prognostic indicator. So focal cartilage loss doesn't mean osteoarthritis. So care must be taken while reporting to not to use osteoarthritis when interpreting focal cartilage losses. Osteoarthritis term is usually is a clinical and a radiographic diagnosis, not an MRI diagnosis. It basically implies a generalized disease where there is diffuse attenuation of the cartilage in varying thickness and varying levels of severity, not a focal chondral loss. And also the management differs for both. Where in focal cartilage lesion, the management is either conservative or some surgical procedures for cartilage implantation, whereas osteoarthritis is mainly physiotherapy and arthroplasty. Therefore, it is misleading to equate any focal high-grade chondral abnormality to a severe arthritis in a knee joint, especially when the radiographs are normal or near normal. So it is important to define the cartilage damage with respect to what is the thickness of the damage, are there any subchondral changes, what is the size of the damage, because the management differs according to the type of cartilage damage. If there are any focal cartilage damages like softening of cartilage or partial thickness cartilage, based on the patient clinical scenario, if the patient is a senile person, then such cases can be ignored with conservative management. Or if the patient is a physically active individual, then option of chondroplasty, that is smoothing of the degenerative cartilage, may be given to the patient. It is basically trimming of the unstable margins. In full thickness cartilage defects, measurement of the size of the cartilage defect is important, because smaller lesions, that is less than 4 centimeter square lesions, can be in such cases marrow stimulation procedures, that is microfractures or subchondral drilling, can be performed. Whereas in larger lesions usually require a Oates procedure or a autologous chondrocyte implantation. Osteochondral lesions, there is quite overlap between osteochondral lesion and osteochondral defect. So osteochondral lesion is an umbrella term where it is used for any acute or chronic localized disease involving the cartilage and the subchondral bone, whereas osteochondral defect where we have a scalloped fracture line. So osteochondral defect may be because of various causes. It is maybe due to osteochondral fractures, any end stage of subchondral insufficiency or avians. It can be an end stage of unstable osteochondral desiccants or an end stage of osteoarthritis where we have a subchondral cyst with articular cartilage separating from the native bone. A small points about osteochondral desiccants is it is a chronic osteochondral lesion in young adults and children. So osteochondral desiccants differs from other osteochondral lesions because it is a inside-out lesion, whereas other osteochondral lesions are outside-in lesions. So there is a grading of osteochondral lesions where there is initially separation of the bone, which progresses into the cartilage on one side, then to both sides, then and the end stage the osteochondral fragment is separated from the native bone. So there are some clinical signs of instability mentioned when we have a high signal changes between the native bone and the osteochondral fragment, or there is any fluid-filled cyst beneath the bone. Next is subchondral insufficiency fractures. They usually seen in weight-bearing areas. There are some 4 signs described for it. So we have a hypointense irregular subarticular fracture line. So that indicates a fracture callus or granulation tissue. Beneath that, we have a area of low signal intensity, creating an impression of a thickened subchondral plate. This usually corresponds to an area of secondary osteonecrosis between the fracture and the articular surface. Then we have some deformities in the subchondral bone plate, or in the later stages, there may be a fluid-filled cleft between the bone and between the condyle and the bone, which indicates there is gross collapse and impending separation of the fragment. So to conclude, it is important. The teaching points of today's session are: it is important to identify early cartilage lesions, either on morphological or compositional imaging, because these may further progress to full thickness or partial thickness chondral defects. It is important rather than grading, it is important to mention whether the cartilage injury is partial thickness or full thickness, because the surgical or conservative management will depend on the amount of thickness rather than the grading. And it is also important for us to know that some types of sequences may affect the grading of cartilage damage. Few sequences like T1 sequences might under-report a cartilage grade. Mapping techniques like T2 mapping or digimeric sequences, their diagnostic utility is usually reserved for early cartilage degeneration. But the utility diminishes in late advanced cartilage degeneration, where the lesions can be easily picked up on morphological imaging itself. One keynote point is subchondral bone marrow abnormalities. It is important to mention these things in a report, even though if we don't find a significant cartilage defects, because the presence of a cartilage damage during arthroscopy, even in cases where the cartilage appears normal on MRI, is present when there are associated subchondral marrow abnormalities. Sometimes the MR scanners cannot resolve the cartilage damage corresponding to the subchondral marrow changes. So sometimes we have a grade 2 cartilage defect with extensive subchondral marrow changes. That doesn't mean the cartilage, rest of the cartilage is normal. It is just inability of the MR to resolve the damage in the residual cartilage. Also, the significance of cartilage injury with regard to risk of OA progression is dependent on other structures in the joint. Also, clinical and radiographic correlation is important. So, only cartilage damage doesn't mean osteoarthritis in isolation. Thank you.
Thank you, Dr. Vikram. That was a wonderful presentation from you. Now I request Dr. Sunil sir to share his suggestions regarding the utility of this imaging modality and its regular practice, sir.
Presentation. And here I would like to add something. From a orthopedic surgeon's perspective, when you're looking at cartilage, you are basically looking at 2 categories of patients. One is the younger age patients and second is the middle age patients. When you come to the elderly patients, obviously this thing of cartilage is less importance because we find their changes on X-rays. When we come to the younger age patients, as you have rightly pointed out, they are more like osteochondral lesions. That is what we are looking at. We are looking at patients who come with us with knee pain or say history of patellar dislocation or say shoulder dislocations. Then we are looking at osteochondral lesions. That is what we are looking at. And these, we need a specific answer because these need to be fixed. All these osteochondral lesions, they need to be fixed, and it is not that difficult to fix them. That is number one. Number two is coming to the way in which we treat an osteochondral lesion, say in a knee, in something like an ACL injury with an osteochondral injury. How do we treat it? Microfracture, yes, we do it sometimes, but we are using it less and less these days, because what happens is with microfracture, you get a fibrous cartilage. It's scar tissue. It is not hyaline cartilage. And the problem with scar tissue is it doesn't resist the shear forces. In all the joints, we have shear forces. And this type of collagen, this type of cartilage which is there is not conducive for transmission of shear forces. That's the reason we are using less and less. If there is a clear-cut osteochondral lesion or a chondral lesion, then we do what is called Oates procedure, that is osteochondral transfer. We take a chunk of bone with cartilage from near the edge of the trochlea and we transfer it to the weight-bearing side. The problem with this is it is very easy to integrate because there is bone involved. So whenever there is bone, as we know, the healing is faster. The thing is, you have got a host site problem as well. But the main issue here is we are not always able to surface match the cartilage from one area to another. That is, in the weight-bearing area, the curvatures which we are talking about, we might not be able to match it always. We try to do as good a job as possible. What we don't want is we don't want a proud osteochondral plug. If anything, we recess it, we push it a bit more inside, but we don't want it proud, definitely. A proud lesion causes problems. And when we come to kids with patellar dislocation, it is very, very, there is a very high chance that these kids, especially, when you get an X-ray done and there is a small flake of bone seen, actually there is a huge chunk of cartilage attached to it. So these kids, we want to see them as soon as possible, because you see, for these things, if you report it as a proper osteochondral defect with a loose piece lying in the joint, then it is paramount that we fix this piece of joint, because they are young kids, they heal very, very well. We can use what are called biopins, that is bioabsorbable small pins, and we fix these fractures and they heal pretty well. Now, when we come to slightly younger patient, especially women 30, 35, 40 years, they complain of anterior knee pain when going up and down stairs, when squatting, getting up. These people tend to have chondromalacia patella. We really don't understand what's going on when we say chondromalacia patella to be. Yes. But these people, when you subluxate the patella and see, there is tenderness on the lateral facet or the medial facet, and these things are very beautifully picked up by your cartogram that you have described. When someone has a persistent problem and it doesn't get better, then we send them, because not necessarily these lesions are morphological lesions. These are more lesions where there is alteration. And they normally get better with time. That's the reason we delay sending them to you. And now when we come to the third category, when you have a typical slightly degenerative joint in a 45, 50-year-old person, here always a cartogram or a cartilage evaluation goes with a limb alignment. So here we always want an axis measurement. That is a weight-bearing, long leg, and we measure the mechanical axis and see what are the mechanical stresses on each compartment. That is what we want. We want the cartilage to be correlated with the weight-bearing scanograms. That is what we want. And here the problem with MR scans is because MR scan is not a dynamic thing. It is a static scan where it is non-weight bearing. So we don't know the intense lesion that you are seeing on MRI scan correlates when the patient is standing or doing activities. So especially nowadays, what is happening is we are tending more towards preservation of joints. We are moving a bit away from the arthroplasty, this thing, because we all know the problems associated with arthroplasty in young people, where it can loosen quite early, and it can cause more problems. So we want to preserve joints, especially when we are thinking about medial joint, where you get a bit of arthritis, and then you get these typical, you see the meniscal root lesions. Yeah. And these are the patients whom we want to know. If there is any cartilage damage with a meniscal root, then I would rather do an alignment alteration, change the alignment of the knee along with the root report. So in these cases, it becomes very critical to find out. But as we said, most of these lesions, they are morphological. That is, you can see even on good quality plain MRIs, you can see the cartilage. And that is what we want to see. Even the subchondral edema and everything is properly seen. So we know about these lesions. That is what I would add to this thing. It was a very good presentation. Thank you.
Thank you, sir.
Thank you, Dr. Sunil sir. It was very nice of your concern for sharing your views about this topic. I thank Dr. Vikram once again. I thank Dr. Sunil also for attending and sparing his time for this discussion. With this, I would like to close the session.